For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Kathrin Berg.
Obesity increases the risk of heart disease, of diabetes, and many other medical issues. For most people, diet and exercise has not always worked. There is a current trend, I'm sure everybody's heard about them, we're going to talk a lot about it tonight, the weight loss medications, but the jury's still out on what the long-term effects of that is. So bariatric surgery might be an option for you. This evening's program is underwritten by Providence Medical Partners, and we want to say thank you to the El Paso County Medical Society for bringing the show to you for 28 years now. I'm Kathrin Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Thank you for joining us. The topic today is slimming down for a stronger heart. I know that we talk about obesity, we talk about people who are overweight, and a lot of times it's like, well, I just would look better. We're not talking about looking better tonight. We're talking about how to be healthier, how to slim down for a stronger heart. So thank you for being here. Dr. Clapp, we were just talking, you said this is probably the 7th show you've been on. And you were with us back when we were at the UTEP studio. And so that's probably like 26-ish years ago. So thanks for sticking with it. But we have Dr. Benjamin Clapp here, and he is a general surgeon specializing in weight loss. But again, you do all kinds of surgeries. We also have Dr. Ricardo Kosturakis. He says, you know, if you can't really say it, say Costa Rica, and it just puts a nice feeling in your mind. But you are an interventional cardiologist. So we're going to talk a lot about prevention and how things go on in the world of cardiology. But with that being said, Dr. Clapp, again, general surgery, yes, we're talking a lot about weight loss today. How is your all day, every day in the role that you're representing today? Like, what do you do all day? How often do you see patients? How often do you do surgery, et cetera?
So I've been in El Paso for a long time, and I went to Coronado High School and spent some time even at UTEP, and I went to med school at Texas Tech. So I've been back in practice for 19 years. And for that 19 years, I've been a bariatric surgeon and also doing general surgery. So what bariatric surgery is, a better term for that is weight loss surgery. I focus on things like gastric bypasses, gastric sleeves, revisions, and other kinds of operations. Now, in El Paso, you can't really do that full time. There's not enough volume for that. So I do general surgery. I still do foregut, hernia, gallbladders, and my daily life is doing things like that, operating. I operate 4 days a week. But I just became a partner with a tenant with their hospitals, Providence, and especially the Memorial campus. It's been a real positive change. I left my private practice after 19 years and started on May 1st. I'm happier every day. So I get to just take care of patients and not have to worry about the business aspect of this. So I'm really happy to be here, and I'd like to talk about obesity. It's one of my chief research interests. It's one of my chief interests in my practice. And you just can't be a physician in the United States today and not have to deal with it.
Exactly.
So I think it's really important. I'm really excited to hear what the cardiologist has to say about it too.
Excellent. And we're going to talk about causes today because it's not just overeating. There's a lot of stuff that's involved too. So I would love, Dr. Kosturakis, if you can explain, again, you're an interventional cardiologist. How is that different from a cardiologist? How is that different from the other types of cardiologists that you hear about out there?
Yeah, so general cardiologists are specialists that do a single specialty or fellowship in cardiology. Within cardiology, there are multiple specialties like electrophysiology, interventional cardiology, heart failure cardiology, and we subspecialize in more specialized areas within the cardiology field. Interventional cardiologists perform invasive procedures or angioplasties, traditionally of the heart and the coronary arteries, but also of the peripheral arterial system, legs, arms, carotids, mesenteric vasculature. And in the recent past, Interventional cardiology has grown significantly, and now there's a subspecialty of interventional cardiology called structural interventional cardiology.
Yes.
So now valve replacement, repair of congenital defects, and implant of different devices to treat different cardiac conditions are done with minimally invasive surgeries or interventions and don't require open heart surgery like they did 20, 30 years ago.
Okay. So specific tonight, when you're looking at cardiology and then you're looking at people who are, and again, we can talk about overweight, obese, morbidly obese, etc. When does the heart start feeling the stress when it comes to people who are overweight? And maybe we can talk about, we can introduce BMI. I think there's a lot of these words that are thrown around that people don't really know what they mean. But because we're talking about obesity and cardiology tonight, when does it become an issue?
I think I separate it in two different problems. The obesity itself is a problem on its own. Patients develop volume overload. They develop increased intracardiac pressures. Their chest is bigger, their bellies are heavier, so it takes extra effort for the heart to do its regular work. But patients with obesity and morbid obesity are also at risk of developing a lot of risk factors that result in heart disease over time. High blood pressure, high cholesterol, diabetes, sleep apnea, and other problems.
Okay.
So it starts affecting patients right away. Those long-term effects of cardiovascular disease, heart failure, blockages in the arteries happen a little later because they're related to those risk factors. But the physiological changes in the heart and the rest of the body occur immediately.
And I'm going to think in the back of your head that when we start losing the weight, how things start reversing and the time frame on that. In the meantime, everybody's hearing about and I want to make sure I say these right, the GLPs, that is the weight loss drugs that are out there right now. And we talked a little bit prior to the program starting that I thought, okay, is this a trend? Is this going to go away? And you said they're probably here to stay.
They're here to stay.
And at this point, they're not. It doesn't seem like research is going to be too negative down the road. But just in general, with the role that you play and what you've been seeing and patients that are coming to you and people ask you questions a lot, what is it that you can say to folks listening?
Well, I think what we should do is define it first, right? So it's a glucagon-like peptide. So it's a naturally occurring hormone inside of our body, a GLP-1. A GLP-1 receptor agonist is a medication, a drug that we've designed to work in that system. And there's about 14 different kinds right now. There's 3 that are generally available on the market. Right now, they're all injectables, but they're working very hard on making oral formulations, so you can take it by mouth. So it's something that we see already. We learned a lot about these gut hormones and the interactions in between the gut and the brain, and how that's controlled during bariatric surgery. Because as we modify the gastrointestinal tract, we look at things like GLP-1, or we look at ghrelin, or we look at other hormones that interact with the neural hormonal gut axis, right? So GLP-1 receptor agonists are a natural byproduct of that. We did so well with them, probably it's actually decreased the numbers of bariatric surgery because they work so well. But we have to look at the limitations and the side effects and what we think is going to happen with these long term. They're phenomenal drugs. I use them myself in my practice, either before surgery to get somebody to a safer weight, or after surgery if they're gaining a little bit of weight, or just if I want to manage their weight just by that, just naturally, because they're eligible to take a GLP-1 receptor agonist at a BMI of 27. So normal weight would be 25, and 27 you can start medications like that. The big issue right now with them, though, is the cost,
right,
and accessibility, and that's not going to change anytime soon. But they're great. I guarantee the cardiologists use them too. They're phenomenal drugs. Very low side effects. Mostly people will feel nauseated, maybe some constipation. It can be very hard to tolerate. So about 7% of people just can't take them. But the average person on a GLP-1 receptor agonist will lose 10% of their total body weight. So if you're 200 pounds, you can lose 20 pounds.
Right.
And about a quarter of patients, 25% of patients will lose 20% of their total body weight. That's really good. That's 40 pounds in somebody that's 200.
So here's a question that in my head I'm begging to ask, right? You lose the weight, and then is this a medication that they will be on, not forever, but forever?
No, forever.
It is. So it really is not, I'm going to lose the weight, I'll be fine, and then, and maybe we could talk about how people have been playing with that thought and idea for a while.
That's a great point, and it is intended to be forever, right? But on the other hand, my cardiologist has put me on 2 different blood pressure medications I'm going to be on forever. And I'm okay with that because I don't want to have a stroke. I want to protect my heart, right? So I don't see those as deal breakers. Now for weight loss surgery, we have to work out the pathways about postoperatively because we have a tool like weight loss surgery, but we can add these medications. But do we need to run them forever? Can we do a lower dose? Can we do them every other week? So those sorts of things need to be figured out, but the drug is intended to be used forever.
Okay. So this leads me to a question for the cardiologist. So, and I love case studies. And I think case studies are easy for people to understand. Well, this person, this was the situation. And I'm going to say, let's not work in BMIs because I think that's hard, but let's say someone who is 200 pounds and they're 5'7"-ish, 5'8". So that is obese. When is it morbidly obese? I don't know if we want to do the calculations. And the reason I'm asking this, if they're able to lose the 20 pounds, so they were 200 pounds, now they're 180. As a cardiologist, when and how does that start helping with the heart? You were talking about, and I love how you said it earlier, volume overload. And that's volume blood, you're carrying extra stuff around, your heart's working a lot harder to just get out of bed, go to the bathroom, walk around the hall, etc. When does that start decreasing in issues?
You can see changes right away with the first few pounds of weight loss. Blood pressure is one of those things that you can see linearly decrease as weight decreases. Every 5 to 10 pounds of weight loss will result in about 5 points drop in your systolic blood pressure. And the physiological changes are also linearly with weight loss. As the weight starts coming down slowly, the patients feel better, they can breathe better, they can exercise more, their functional capacity increases, their plasma and blood volume starts decreasing right away as well. And it's a slow process because weight loss can be slow. They're not going to lose 20, 30 pounds in 1 month, but 2, 3, 4 pounds per month sustained over a year, the patients will start feeling much better immediately within the first couple of months.
Okay, so this is This is great because this is like a great volley back and forth. Going to Dr. Clapp now, and let's just say we have a patient that for 20 years has been obese, has tried everything. Maybe, has tried a little bit of these weight loss drugs too, but they really do need a bigger intervention. So we're looking at maybe bariatric surgery at this point. What has been the questions going into the bariatric surgery, the pre-op questions, the prep questions, like, let's look at this in 6 months. Until then, talk about how, and I know everybody's different. I'm in full respect of that. But throw out some things that you guys have dealt with.
So first of all, you said the patient had obesity for 20 years. I would step back and correct that. The patient suffered with the disease of obesity for 20 years. It's a disease.
Okay.
And so what we have to think about is it being a disease, just like diabetes is a disease, or hypertension is a disease, or hyperlipidemia. And so when you have this person that has a disease, we have different modalities of therapy, right? And if somebody comes into your office and they're a diabetic and their blood sugar's out of control and a hemoglobin A1C of 13 or their sugar's 400, you're going to hit them with really big medications and try to get that under control. But they come in and they're just a little out of control. Their hemoglobin A1C is 6.7. They're a diabetic, but you're not going to just jump to insulin, right?
Right.
You're going to start with a first-line therapy like metformin or something like that. So obesity is kind of the same thing. Are we going to jump right to surgery, right to some, which, some people think is an aggressive therapy. I don't. It's probably because I'm a surgeon, but not everybody's going to fit into that same pathway, right? So we have to look at where they are in the stage of their disease. We have to look at how bad the disease is affecting the rest of their body, and we have to look at our available therapies. So maybe it will be one of these medications. Let's try that first. Let's see what happens. If they're one of those few people that can get a 20% total body weight loss, that's awesome. That's great. It's not as good as surgery, but it's really good and it might be enough for them. But if they're heavier, if they have a further disease progression, it might be better to intervene with something a little more aggressive. Again, just like diabetes or just like cancer, you don't just do one thing and that's it. And you're never going to do anything again. If you can't get them controlled, you're going to add another therapy.
Right.
So I want people to think of first of all, that obesity is a disease. It's been recognized as such by the Centers for Medicaid and Medicare since 2012, and we know enough about it now to say that confidently. But we also want to think about progression of disease, escalation of therapy, and things like that. So we don't just jump to one thing.
Okay. So when they're coming to see the cardiologist and they're thinking, okay, I'm breathing harder, fine, maybe I'm out of shape, maybe it's my heart, maybe it's the obesity, etc. When is it that you find a time to send the patient over to Dr. Clapp for true intervention?
I think it's important because he probably sees the patients in their later stages of their disease. I tend to see them at the very beginning. A lot of times I see patients that have been suffering from obesity for 15, 20 years, and I'm the very first one to address their disease. They've been seeing doctors for years, but no one has really thought about, hey, let's do something about you being so overweight.
Right.
So I always address their weight, their BMI, and their obesity, and I always give them the option of lifestyle changes. I always reinforce how important it is because, as we're probably going to talk about, if you go on these medications for 2, 3, 6, 12 months, lose weight, and then come off, but your lifestyle is the same and you haven't made any changes in your habits, then it's going to come back.
Precisely your point.
So
Right.
diet, exercise are
Right.
incredibly important, and they also make patients feel better.
So we've thrown out the word, and this is my bad, we've thrown out BMI a couple of times, so body mass index. And Dr. Kosturakis, if you could explain what that is and how people like literally that are listening right now, they can get on their phone and figure out what their body mass index is. So explain what that is, number one, and how they can find out where they are.
It's a patient's weight in relation to their height. So if you're short and heavy, your BMI is going to be higher than if you're tall and slender.
Okay.
And we use BMI because it's easy to calculate, and that's what all the studies use to measure the severity of obesity. And later in the last few years, maybe decades, we've also been focusing on not just BMI, but also abdominal adiposity and abdominal fat.
Oh, let's talk about that. Yes.
So waist to hip ratio is also
Right.
very important to know.
So with those listening, BMI, so if you want to go to any search engine, just put on their BMI BMI calculator, thank you, and that's body mass index calculator, but I think BMI calculator, you can get it. And so you can kind of find out where you fit on that. And Dr. Kosturakis, I love that you said this. So there is also waist to hip ratio, is that what you said? So there is, because it's not perfect, it's not a perfect science, like I have 2 kids that at the same age, one was a rock and the other one was a feather, but they looked exactly the same. They were the same, just, this is a whole different thing. Abdominal weight, abdominal fat. How is that calculated? And I'm embarrassed because I don't know much about it. And Dr. Clapp, if you want to throw that in there too.
Ratio for that.
Okay.
But I mean, you could
like
get
literally
really,
just measuring waist hip ratio. That's
inches
it.
and inches and get a
Okay.
ratio.
I mean, we can get pretty complex with very
Yeah.
simple tools. Like there's a lot of scales that are commercially available that will tell you your fat-free mass, your lean muscle mass,
Right.
your fat composition. And most gyms will have a scale like that. And interestingly enough, when we look at GLP-1 receptor agonists versus surgery, we see protein loss in both of those. We see lean muscle mass loss in both of those, which is why we kind of want to focus on high protein intake when people are in that rapid weight loss period with the medications or the surgery. And we see a greater effect of that on surgery from surgery than we do for the drugs. So those are sorts of things we have to address as we start using medications like this. As far as long-term side effects, there's been some reported issues about thyroid cancer, pancreatitis, things like that. The pancreatitis, I think, is more of a real issue. I don't know what your experience has been.
With these
But
medications?
With these medications, but they're still
Okay.
very, very small numbers.
Right.
Now, that
And
being
it's still
said,
early.
yeah, if you take people out 1 year, only about a quarter of them are still on the medication at 1 year. So there is something going on there that we have to think about, whether it's the injection once a week that they don't like, or maybe just the cost, or maybe they just fall off of it. So what I would say about these medications is they're first generation. And as we see the second and third generation come out, the combos come out, I think the sky's the limit with these medications. I think they're great. I think they're going to change our society. I think they're going to put a lot of doctors out of jobs. I mean, when you look at the downstream effects of obesity and we start using these in our children, you literally are getting rid of coronary artery disease, of diabetes, hyperlipidemia,
All these comorbidities.
Strange, it affects alcohol consumption. It decreases alcohol consumption. So the downstream effects of these medications are going to be astounding, I think, and they're going to change our society.
Interesting. So I can't wait to see what's going on in the next, several years. I will tell you, I don't even know if this is appropriate to bring up or not. I'm 58 years old, been through menopause, and women our age just gain the extra 10 pounds. And they just kind of hang out there. And so I do have friends of mine my age, exactly the same situation, that are taking these weight loss medications. In my head, I'm like, if you just, walk around the block a couple of times, you lose that 10 pounds. But that's me talking, and I know that's judgment. And the reason I'm saying that is because I know I've been judgy about it. I've thought my process of thought has changed quite a bit since I first thought that. So when we're looking at bariatric surgery, because before these weight loss drugs came in, that was a judgment, right? How is it that that enters mentally? When patients come to you, it's like, okay, well, you know, I'm 30 pounds overweight. I'm not morbidly obese, but I'm obese. I do have my cholesterol, et cetera, et cetera, et cetera. I would love for you to just go through a conversation with a patient that comes to you and is contemplating whether or not they want bariatric surgery.
Well, so that's a great question, because essentially almost everyone that comes to me nowadays has been on one of these medications, has tried it.
Okay.
So they've tried it and they didn't have the results they wanted, or they found it expensive or hard to get. And so it's very, very common that most of my patients have already tried this. And so I think what we're seeing, again, is like you said, you know, we're seeing he said that I'm seeing the extreme or the later in the disease process. So for me, that's fine. I'm very comfortable that the patient's tried everything, including these new medications. And now let's go ahead to the therapy I can offer, which is surgery, right? And again, that's not for everybody. We actually operate on less than 1% of people that are eligible for it in the United States. But
say that again. You operate on less than 1% of people who are eligible.
Yeah.
Huh.
Yeah, and it's
Why
funny
is that?
because insurance coverage has gotten better. About 80% of people are insured for this, but there's a lack of access. There's a lack of understanding about it. So it's almost comforting that they've tried everything and now they're going to come to me. Now, I don't want to say that surgery is the last resort. It's not. But I like that the patients have invested time, effort, diet and exercise, and now medications. And then if they need my help, then I can help them. But if you're 350 pounds and you lose 20% of your total body weight, you're still 275. So
Right.
you may still have health effects from that.
Exactly.
So I'm okay with that. That's fine. Try it. And then even in the best case, I might still have to be there to help some people.
So talk a little bit about, and I'm going right into it just because somebody now has had the surgery and there is different life change that they have to do. There's different ways that they have to eat. There's different supplements that they have to take. Talk a little bit about that. And then I'm going to ask another cardiology question, but I want to come back into the differences between the gastric sleeve and the bypass surgery. What has, I want to say there was one that was used a lot more before, and now it's being taken over.
Sure, I can talk about that.
Yeah.
So after surgery, patients do have to commit to lifelong change, right? And then it's going to be a lifelong adoption of a new, healthier lifestyle. Some people will say surgery is an easy way out, or it's the last resort. And I don't want people to think of it that way.
Right.
If you needed we're seeing less and less cabbages or coronary artery bypass grafts, but when he really thinks that's the best thing for a patient, he's going to send it to them and they're still going to do it, right? And those patients don't argue and say, well, I don't need a heart bypass. I can do this on my own. I just need diet and exercise. So we need to think of like a gastric bypass, for example, in those kind of terms. You reach a certain point that no matter what medication we give those patients, it's not really going to be enough. And so at that point, it becomes a life-saving effort. But the patient has to be willing to adopt a new healthy lifestyle, a new diet. They have to be willing to diet and exercise the rest of their life and take vitamin supplementation the rest of their life. So it's really important.
So here's the ugly question. When they don't take care of themselves after the surgery, what happens? Is this now something that cardiology comes back in?
Well, the most common thing that happens
Because some patients aren't great patients.
If somebody just doesn't want to follow the program, the most common things are going to gain weight again. But they can have things like vitamin deficiencies, or they can have things like very rare but very serious vitamin deficiencies or protein malnutrition. Generally, it's going to be weight regain because they kind of go back to their old diet. But I have seen other complications like that.
Okay. So as the cardiologist that comes to be, and I want to stay on bariatric surgery for a little bit still. So now this is someone who has been through the surgery. Maybe we can look at two different individuals. One that is doing everything that they should be doing. They are a class A patient, everything's going right. And there's one that's not. So now you are the guy dealing with, and the reason I say this too is that people who are listening is like, oh, I'll just get this and I'll be done. But it's not the case, and it's not ever the case. So I'd love for you to kind of walk us through someone who is doing everything they should be after the surgery and someone who's not, and how that affects their entire cardiology system.
So if they're doing everything they should be after the surgery, they're losing weight, exercising, dieting, their risk profile should decrease over time as their blood pressure comes down, glucose comes down, lipid levels decrease. But some just don't. Some lose the weight and they're still hypertensive. They still have high cholesterol. And just because they lost the weight doesn't mean they're risk-free. So I still continue to check their levels once or twice a year, recommend medication if appropriate to maintain appropriate levels of glucose, cholesterol, blood pressure. And if the person had surgery but they're not following any of the recommended therapies after the surgery, they're just back at the beginning. So starting over again, let's talk about your habits. Let's talk about what you're eating. Are you exercising? Are you eating at home, eating out? Let's talk about medications again and just continue to check. In cardiology, we see a lot of, most of my patients I continue to see for the rest of their lives. So I have a long time to continue checking and reinforcing the importance of appropriate lifestyle changes.
Okay. And when do, if any, and I'm thinking about specifically cholesterol, because I feel like statins, there's always medications out there, not the weight loss medications, but medications that help with hypertension, that help with cholesterol, that help with this and that and the other. Are those any different in patients who have had bypass surgery and or sleeve surgery? And again, I haven't, or is that the same for those patients?
So, I mean, to go back to the previous question, that's the person that's coming off track. I would put on GLP-1 again.
Okay.
Because there's no reason not to use it after surgery.
Okay.
But,
there's no reason to use it, not use it after surgery.
Absolutely use it to get them back
so they've
on
had their
track.
surgery, they can go on this medication as well.
Yeah, but as far as other medications, I mean, we will generally cut back some medications, but there's going to be things where the cardiologist says, well, look, we're giving this medication for maybe a renal protective effect, like an ACE inhibitor or something like that. Or maybe you have this bad family history of hypercholesteremia, so we're going to continue to treat your, that. You might be able to draw some of those back, but we can't change what's happened in the past, and we can prevent progression of disease, but like if somebody's already got a bunch of plaque buildup in their arteries, that's not going away. So we still need to treat that.
Right.
So what I like to do with my patients is get their doctors involved, let them, we need to co-manage this because there's gonna be some things that are gonna get better and maybe even go into remission, but there's gonna be a lot of stuff we still have to manage.
So I'm going to ask you this question too, because I know on previous shows that we've done, it always fascinates me how you describe the two different procedures that are most popular. The gastric sleeve, let's talk about that, and then how to talk about the bypass surgery. So which one do you want to pick first?
Well, the most common operation in the United States today is the gastric sleeve. And so what we do with the gastric sleeve is we resect a portion of the stomach. So the stomach and the bowel remains in continuity, but we essentially trim down the stomach and remove about 80% of it. So think of a garden hose that's about this long and about the thickness of a garden hose. Great operation. It is safer than the gastric bypass, but these numbers are really, like less than 1% sort of risk factors from surgery. But people see it as simpler, easier, so it's become adopted more. The gastric bypass, on the other hand, has been around for about 65 years. And what we do is we make a very small stomach, the upper portion of the stomach, and then we divide the intestine, bypassing the older portion of the stomach, and we bring that up, creating the new anastomosis or connection to the gastric pouch. So food goes in, but it bypasses the old stomach. So that's kind of stood the test of time. We know its ins and outs. We've done hundreds of thousands of these over the years. It's been around forever. It's a great operation still. There's a couple of other operations that we offer. There's one called the one anastomosis gastric bypass, where we do the same sort of thing, but with one connection instead of two. And there's a thing called the duodenal switch procedures, which I do also, which are essentially you bypass the intestine. So it's more of an intestinal bypass than the gastric bypass. They're all done with a robot with 4 little holes, 5 little holes. They're all about 1 night in the hospital. They all have about the same safety profile as a gallbladder surgery. So, so yeah, I love doing them. Yeah.
That was a surgery I was going to ask you about a couple of months ago. There was somebody that needed their gallbladder out. Again, general surgery, but also dealing with weight loss surgery. So here's, are there any patients that have certain conditions? And again, you do a full follow-up and pre-op and everybody else. Are there certain patients that simply should not have bariatric surgery?
Well, right. So that's a great question. I mean, it's kind of a loaded question.
Yeah,
we do tend to.
It is, but I thought,
we do tend to, I mean, most people we can offer something, but there are a couple of conditions where we really don't want to do surgery. So for example, if someone's an active substance abuser, whether it's alcohol or any other illegal substances, that's not a great idea. People with active psychoses, not a great idea. we shouldn't be doing those.
Okay.
Medically, I mean, we have to look at that and look at their medical risk and get our colleagues involved. But I mean, I've done operations on people on the transplant list to get them to a transplant, you know, so they can safely get like a heart, I mean, not a heart, like a kidney or a liver transplant. So we can do those. They are higher risk, but we very rarely turn people down for medical problems. It's more for other issues.
Okay, that's really good to know. That's really good to know. Okay, Dr. Kosturakis, I keep looking at your name, making sure I say it right. In general, we've been talking, so again, as an interventional cardiologist, am I right in saying that you're trying to do a lot of prevention of what's happening? I know you're intervening in what's happening and going on. So talk about some of the things, bariatric surgery aside, that you, and let's say also the medication aside, since that's still kind of new, but just old school. What are some of the interventions that you have done? And when I'm thinking that it's not necessarily about obesity, but when we're looking at putting stents in, maybe it is a little bit because obesity or because of cholesterol. Again, I got all these comorbidities that are together. What are some of the things that you've had to deal with? And kind of specifically in El Paso, because I know El Paso, we've seen it, unfortunately. We do have a higher obesity rate here than many other cities. I know we have a very high prevalence of diabetes. So just kind of on that train of thought.
Right, so I'm an interventional cardiologist. So I train interventions, I perform interventions, but I do that once a week. So
You do that once
80%
a
of
week,
my
okay.
time I spend in the office seeing patients, practicing a combination of general cardiology and interventional cardiology. So this is something I address on every patient. We're talking about, you know, when is a good time to intervene. I think it's as soon as we can, and as soon as insurance will allow us to, because it's a cumulative effect. The longer you live with severe obesity and risk factors, the more likely you are to develop heart disease. So if we intervene early in the disease stage, then the risk of having heart disease and multiple risk factors down the line actually decreases. As far as cardiac interventions related to obesity, I don't think there's much. Obesity can definitely complicate my interventions because a lot of the procedures I perform are done from the femoral axis. And there are patients that are so obese that I cannot perform procedures because the risk of bleeding is exceedingly high. So it can
take that and expand a little bit on that. And where I'm going with this is, again, the issues that can happen that may not be in play right now, but the issues that can happen to you when you are obese. And I guess here's the other question. Sorry, I keep throwing them out. Cindy, you know what? We have an audience here today. I'm going to ask one of you guys to pick up your phone and do a BMI calculator, because my question is, once you get past a certain BMI, when you know you're gaining weight and you're gaining weight and you're gaining weight and you're just not able to lose it, now all of my risks are what? And again, as a cardiologist that follows a patient through and they're just gaining weight every year, what do you physically see happening in those patients?
Okay. So you start seeing their blood pressure go up. I think is one of the first changes you start seeing is hypertension. I think lipid metabolism takes a little longer. I think the body adapts.
Oh, we haven't talked about lipids at all.
I think the body kind of adapts to it in the first stages, but once all the rest of the metabolic changes start happening, like diabetes and glucose intolerance, then hyperlipidemia starts becoming a problem. Their triglycerides start going up, and that just turns into a vicious cycle where they have high glucose, high lipid levels, they gain more weight, then more weight results in even greater glucose levels and cholesterol levels.
And so for a layman, which is me, I'm thinking, okay, so my cholesterol is fine, but I have high triglycerides. Why is that a problem?
It's still a problem. They're all lipids, and triglycerides, LDL cholesterol, total cholesterol, all those result in, when in excessive levels, they all result in early atherosclerosis, which is the disease process that results in blockages in all the arteries of the body, not just the heart.
Now describe what atherosclerosis is.
It's a disease process where initially cholesterol and lipid start to deposit in the vessel walls, and that results in what we call intimal injuries, or also known as plaques. Plaques are deposits of lipids initially, and then eventually inflammatory cells and calcium and other molecules that lead to blockages.
Oh, okay.
And those eventually will...
She's like, she needs a password.
No worries. And those will eventually get big enough that they start obstructing blood flow inside of the artery, or they rupture and create a heart attack or an acute lung event or a stroke.
Okay. And again, where I'm going with this, and I feel like I don't feel like I'm running out of questions, but I'm trying to really bring home the point of it's so easy to gain weight and it's so easy to blow it off until you're at a point where all these things, like you said, are now in play. It's not like plaque's just gonna go away tomorrow. So as an interventional cardiologist, you have to now go in and atherosclerosis, which I say wrong. Are you going in there and now stenting? Are you going in there and trying to take some of that plaque away? How are you dealing that now that this person has an issue by not dealing with their weight for all these years?
So different severities. You could have mild atherosclerosis and be completely asymptomatic. That's the person that typically receives medical therapy, aspirin, cholesterol, glucose control, blood pressure control. Once the atherosclerosis becomes significant or severe, patients will have some symptoms. If it's in the heart, they'll have either shortness of breath or fatigue with exercise or chest pain. If it's in an artery of the leg, they'll have what we call claudication, which is leg pain with exercise because of decreased blood flow. Or if it's in the brain, they could have TIAs or strokes. So as a cardiologist, if it happens in the leg, I typically do a non-invasive workup, ultrasounds, pressure measurements in the leg. And if there's signs of severe blockages, then I do an angiogram, which is an invasive procedure where I inject contrast into the artery and I look under X-ray. Right. And if the blockage is severe and the patient has symptoms, then the best way to treat it is by opening the blockage and restoring the normal blood flow. If it's in the leg or the heart or in the brain, but that's the neurologist that would do that, the brain blockages, the arteries.
And the effect is almost immediate, I'd imagine?
If they're symptomatic, their symptoms should go away if they're related to the blockage, and 99% of the time they do.
So and I've heard about stents too, it's like you have a stent that's put in and maybe 8 years later, it might be time for another stent. How common is that?
So the stents have evolved quite a bit in the last 20, 30 years. Now we're in the 4th generation of drug-eluting stents. So one of the downsides of stents is that they restenose. So they form blockages inside of the stent. And there's 2 types of restenosis. You can have de novo disease, the same process, the atherosclerosis that affects your native arteries, also affects the inside of the stent. But there's a very small number of patients that develop this hyperreaction to the stent, and they get stenosis within a year or 2.
Wow, that quick.
Yeah, if it's just regular de novo disease inside of the stent, we quote rates of at 10 years, 50% of the stents should be open. 20 years ago, it was 3 to 4 years. When it happens, because of a hyper response to inflammation, it usually happens within the first couple of years.
Okay.
So I tell my patients, getting a stent is not curing them of their disease. I'm just using Band-Aids. I don't take the plaque out. All I do is put a stent in there. But once they get a stent, now they have to be on a couple of medications to keep that stent from forming blockages. So I tell them, you're trading one disease for another disease that we can control a little better or a little easier.
So since I'm sitting here listening to you, how can you describe to someone who has no idea what a stent is, what is the stent doing physiologically in your arteries?
So when a plaque is severe, the walls of the vessel have 3 layers. The most inner layer is called the intima, and it's a very thin layer of tissue, but it's very active. It communicates with your blood all the time. There's a lot of channels there. There's a lot of cytokines that those cells release that control how your arteries dilate or constrict in response to different scenarios. So in patients that have atherosclerosis, they lose that control of their arteries. And what happens is those plaques can either stabilize over time and form essentially a calcium shell. So they can keep growing, but the risk of those plaques rupturing goes down. When I use a stent, in order to open the blockage, I have to dilate the artery in order to treat the blockage. And when I do that, you cause tears in that inside of the artery, which puts the patient at risk of having a heart attack. So before there were stents, we were using a balloon angioplasty 40 years ago. You would open the blockage with a balloon, and then 2, 3, 4 hours later, they would come back with a heart attack because the vessel just occludes. So the stent is a scaffold. I tell my patients, think of it as a spring in a pen.
Holds everything open.
Yeah, it's a spring in a pen. It comes loaded in a balloon, crimped on a balloon. The balloon is expanded inside of the artery. The stent expands, and it has memory. It retains its shape. So it keeps the artery open, and it keeps it from recoiling.
Now, if I remember right, and I could be wrong, are there stents now that have medication built into them?
Right. So now the great majority of the stents that go in the heart have medication around it.
And what is that medication doing?
It prevents that restenosis. So that's
Okay.
why the restenosis rates went from 50% in 1-2 years now to less than 50% as long as 10, 15 years.
Okay. All right. I'm going to go to some lifestyle. So I have some questions here just from shows, and we joked. These are my notes from literally the last 20 years on when we did anything with bariatric, but I would like to talk about, you mentioned gallbladder earlier. Somebody has a gallbladder taken out, their diet has to change, the amount of fat that they are no longer able to consume, etc. When somebody has bariatric surgery, and I know you had the different processes as well, what is it that they have to change in the diet? I know that we were talking about supplements, and I remember I just read this thing called dumping that we haven't talked about in a long time, and I don't even know if that's a thing anymore.
It is.
So,
I mean,
okay.
I think that I think that the greatest change would be the volume of food that they can eat. So either operation or any operation that we do to them, it's going to really, really restrict the amount of food they can eat. For example, the gastric bypass pouch is about 30 cc's, about an ounce. For the sleeve, it's probably about 4 ounces. So if you looked at something like this, it's probably about 250 cc's. So it would be about half of this, maybe. So,
and that's all the food that
they can eat.
Can get in there without you.
So volume's going to be the main thing. And if they try to
Okay.
overeat, it actually will punish them a little bit. They could throw up. They could feel really uncomfortable. Now, as far as kinds of foods, we really need to stay away from ultra-processed foods because most of those are slider foods. Like think of a bag of Cheetos. You chew it up, it's going to go down. I mean, it's not gonna. No, we haven't invented an operation that can't be defeated
God,
by a
but
bag
I
of Cheetos.
love a bag of
right?
Cheetos.
But so I would say stay away from ultra processed
Right.
foods. Fried and greasy foods would be a very easy thing to kind of avoid. So here in El Paso, having carnitas might not be as good as having carne asada, right? It'd be better to have that. You could have things like sugars, dumping syndrome. I tell my patients less than
And
5.
describe dumping syndrome, just because
Sure.
we haven't talked about
So
it.
dumping syndrome is when you eat sugars and your intestines been bypassed, your stomach's been bypassed. So you deliver like this high load of sugar that's been unprocessed into the small intestine. It makes your body go a little haywire. You know, they get sweaty, have diarrhea, maybe some explosive diarrhea, vomiting, cramps. It's just you have this feeling of doom. So avoiding sugars, usually cutting it off around 5 to 7 grams of sugar a serving would keep you under that radar. And then I like to think of guidelines. So I think of white foods that are made out of starch and flour. You know, flour tortillas, white bread, pan dulce, donuts, cakes, pretzels, chips. I mean, those really aren't great for us. We shouldn't be spending most of our calories eating those. But 50% of what Americans consume comes from ultra-processed foods. It was in the news actually this morning. So those are just some basic guidelines that I would give the patients.
Okay. And that's such a great point because we talked about the world is in an obesity epidemic, especially America, some Mexico, and a lot of it is the foods that people are eating. And I want to say that there is some kind of medical rawness going out to some of the food companies, et cetera. But there's money. It's all about,
it's
money,
all about money
at the end of the day.
What does Starbucks sell, right? They don't sell coffee, they'll sell sugar. They sell sugar.
Right.
And what do they make? They make billions of dollars of profit a year. It's money. No matter what happens, that will never change. So until people start demanding change, corporations will not change. So just thinking about a healthy diet, thinking about learning how to prepare food in a healthy way, thinking about food deserts, where people of a social economic status a little lower may not be able to get to a healthy grocery store. That those are going to be issues that we could address on a public health aspect, but probably will not be addressed.
Okay, unfortunately. And I think there was there was a Jamie Oliver, I think his name was, back when my kids were still in school, was trying to change the school menus because it's cheaper for the school menus to process food, everything, the pizzas, everything that's there. I would love to talk a little bit about what both of you see in your disciplines in the next 10 years that are positive, whether they're treatments, if there's a way to start changing the mindset of Americans. And again, we love our tortillas here. I love them too. What do you see in the next 10 years in your discipline that could be helpful? That's a loaded question. Dr. Clapp knows this question. And I think for you, surgery is almost easier, not easier, but there's tools, there's different ways of doing things. We're talking about the stents that are now medicated, that how much nicer those are now. And I don't know when those kind of came onto the market. Was that a decade ago?
It was like 30 years or so.
30 years or so.
Yeah, I think a big game changer are the GLP-1s. They not only work for obesity and patients that are overweight, but they also decrease cardiovascular risk and cardiovascular mortality, especially the semaglutides. So I think,
talk about what's a semaglutide.
Yeah, so I see patients.
So again, we're talking about people that don't get to hear this stuff all day.
So I have patients in the office that have had a heart attack or have atherosclerosis in their heart or their legs, and they're not diabetic, but they're overweight. And that's a perfect patient to start these medications on because they have heart disease, they have obesity, and the medications are going to help with both. So I think the indications are going to expand and the availability of the medication is going to increase. So I think it's going to be a game changer in the next 5-10 years. We're already seeing some trends in the obesity rates in the last 5 years. We think it's because of the GLP-1s and greater access to all these medications and bariatric surgery and other therapies. So I'm hoping that it's going to continue to level off and hopefully decrease. And also very important, we have to start with kids and adolescents.
Bingo. Absolutely.
There was a huge freak out when they started approving these medications for young kids. And I just can't imagine how you'd be upset about approving a medication that results in weight loss and decrease of cardiovascular risk factors, but be okay with a 12-year-old having a BMI of 35 or 40.
Eating 5 bags of Cheetos a day.
At school.
Right, at school,
Yeah.
Bingo, at school, exactly.
So it has to be policy changes, changes in the medical and health industry, and also a lot more self-awareness.
Agreed. Dr. Clapp, anything that you see on the horizon for you?
Well, for me specifically, for what you say for weight loss surgery, it's not done. I mean, it's going to change. Like already, we see practice patterns that are emerging where we do higher body mass index. Patients that are a lot higher than our normal average. Average up till now has been about a BMI of 42. It's going into the 50s and 60s now because we're going to see that the medications don't work on a subset of patients. So it's not going to go away. We'll be doing just kind of more high-risk patients and patients with more severe forms of obesity. But I don't think we're anywhere near like getting rid of surgery for something like that. And that's okay. I mean, again, we have to think of obesity as a disease, and the continuum of disease is going to require different treatments. So we'll be around doing that. There's some promising endoscopic therapies too, done with through the mouth, not surgical, like opening people up or doing laparoscopy or robotic surgery. Those are kind of promising too. Okay. But I think that really it's going to be the second and third generation GLP-1 receptor agonists that are really going to drive this in the future.
So I don't want to go off script, but I kind of do, because as a general surgeon, and you kind of just mentioned some things that are on the horizon that are coming about. And there was a cardiologist, I know there's a new way of going through the wrist versus the groin on some cardiology things, and that's relatively new. So I'd love to this is where I kind of geek out on what's the Star Trek stuff coming up. Remember when Bones would go over this old, you guys are too young.
Well, the obvious thing is going to be a genetic therapy. So when we start looking at the genetic factors that make up obesity, start targeting therapy to individuals, looking at their genome and maybe even their gut physiology and their gut genomics, where you look at how much bacteria is in our gut, it outnumbers our own cells by a factor of like 100 or 1,000. And so when we start looking at how to really interact with that, and then the genetics of the actual person and modifying them on a genetic level, I think that's the key. Okay. So when we let AI go at that problem, that's probably where it's going to fix it. AI, I mean, that might be put all surgeons out of business. Johns Hopkins has been training an intuitive robot with an AI, and it just did a gallbladder on a pig, completely unsupervised by itself. I actually foresee in the next 5 to 10 years that I'll be a pilot and I'll be watching a robot operate, and I'll be there just in case, just like the guy that flew you here from Dallas last weekend or wherever you went. He wasn't flying the plane.
No, my brother's a pilot,
flying itself,
and he tells me
he's there just in case.
Yep.
And realistically, we're 5 years away from that now. On a level, societal level, being willing to accept that, we can't even accept full driving cars yet. I have one, I love it, let it do its thing all the time. But that could be done with surgery in probably 5 years. But I say within 10 years, we'll be doing that routinely.
So let me ask this in the meantime, because you were talking about just gut health in general. And I feel like it's not talked about as much, but 10 years ago, it's like probiotics, prebiotics, take this, take that. Then there were some that were not approved and then some that were approved. In general, prebiotics, probiotics, what do both of you feel about that? Because it does matter how your gut accepts the food that it's being given, right? So if we're looking at the guy that eats 5 bags of Cheetos and he's not got any good gut health versus the person that eats all of his vegetables.
Well,
in general, is that a hype or is it a real thing?
It's a hype. I mean, the problem is that, obviously probiotics work, and we have to have a healthy bacteria in our gut, and antibiotics will destroy that, and it will kind of mess you up for a little while.
Right.
But when you have over 10,000 different species in your body, and we don't know which one does what, we don't even know how to culture most bacteria that we find in the soil. We can't even figure out how to culture them to grow them. We don't know that yet. So I mean, that's why I think that genetics will be a way to do that. Automated DNA sequencing probably will help, but it's still, there's just so much data to sift through that I think we're going to have to give that over to systems that use AI and things like that to just wade through that, because how do we know what's healthy and what's not if you have 10,000 different species interacting inside your gut? So I mean, whenever I try to prescribe probiotics to somebody, I'm in a quandary, because I don't know. First of all, they're not regulated by the government.
Bingo,
the FDA
exactly.
Really,
it's like, which ones are the good ones?
So I just kind of go with the big brand names and hope that works for it.
Okay, that makes sense. Anything you want to add on that?
Yeah, similar thing. There's a bunch of different probiotics. Some you can find in a refrigerator and they're alive. Some you can find in a little packet or a bottle or a liquid. And we don't know which ones are the better ones and which ones are the worst ones. I think a perfect example is in patients with C. diff colitis, which is commonly caused by overuse of antibiotics. Their gut just goes completely crazy. They have severe pain, diarrhea doesn't go away, 10, 15 bowel movements a day. For a long time, we were giving them different antibiotics, probiotics, and what seems to work best is a stool transfer. So you get stool transfer. So you get stool from a family member, preferably. You get an NG tube, get stool down your NG tube, and it restores your...
Yeah, take somebody with a healthy gut.
This is intriguing me. So someone who's got healthy stool.
Yeah, you stick their poop in an NG tube and stick it in their nose. I guess they could eat it, but nobody would do that, right?
Okay,
we
could do a whole show on that, because now I'm like, what?
You got to be careful with the blender you use. You don't want to reuse it in the
right.
cafeteria, right? I mean, it's got to be...
So that intrigues me in the idea, because you were talking about antibiotics, right? And it takes a while for your gut to get back to normal. So with the idea, when somebody's on antibiotics for a good amount of time and their gut is just messed up, for most people with not taking any probiotics or prebiotics, how long does that usually take for your body to be able to then accept food like it used to? And we were just talking about, getting your poop normal, if we can say that out
that's
loud.
kind of a whole infectious disease conversation that would take a long time to go over.
Okay, all right. So here's a question too. We're talking about genetics, right? And I think when I think genetics, I think about the word of oncology, of the BRCA gene testing, of this and that and the other. I know that's also in with other areas of the world, but I feel like if a grandmother had breast cancer, her daughter had breast cancer, now they're taking genetic tests to see if their children would also have those genes. In the other worlds, in cardiology in general, is that something that is thrown out there anymore? Or is that, I know it's focused on oncology, but I feel like there's a lot of genetic testing of what's happening in the future.
There's a lot of genetic testing going on in cardiology. They're trying to look for different, what we call SNPs, single nucleotide polymorphisms, that can result in a high risk of having atrial fibrillation, heart failure, coronary disease. We've found some correlation between certain genetic mutations and cardiovascular diseases and risk factors, but there's not a very strong direct correlation.
Okay, and there's not really like a reason to be tested, so to speak, like with oncology, with cancers, there is like...
Not right now. There are some cardiovascular conditions that are known to be genetic, but not really for like risk factor like atherosclerosis.
Yeah, it's kind of rare to find like a single gene to cause one thing. I mean, there are things like that, like cystic fibrosis, but those are actually quite rare. Usually it's multi-factor, it's polygenetic. So those are really hard to tease out.
And you touched base on AI earlier. So when I am thinking too of 5 years in the future, just by doing these programs here and there, the ways of testing what your children may have, even in utero. We had a pediatric program on before too, and there was ways of testing things out that aren't physically able to see. Oh my goodness, I can't think of the condition, but on the program, the doctor said the patient that he had, who was a female, and she is now of reproductive age, was strongly suggested not to have babies because of the heart conditions that she would probably have because of her own heart conditions. And it's not really a question, it's just kind of a, where do you think all of that's going to be going in the future?
Well, we'll only get better at it. I mean, as you automate these sort of like the grunt work of it with something like AI, it's just going to get better and faster. I mean, the one thing AI does well is it synthesizes data quickly and it codes quickly. Mm-hmm. So if you're using a computer to make a program to look for a certain genetic defect or something like that, it codes without mistake, a million times faster than a human. So when we use it things like that's what it's good at. And if people are worried about it, they're scared of the Terminator or whatever. But it's like, no,
well, it's 23andMe. There's people freaking out about 23andMe.
Yeah, it's going to take a lot of the grunt work out. It's going to take a lot of the repetitive work out. And it's going to make our lives a lot easier in a lot of different ways.
Mm-hmm. So. And this is where it is too. I think AI, there's a fear, but I think maybe there's a true horizon coming too. That's all good. Even with our fix system, when I say that our information exchange system that we have now, it's not AI, but it's the whole idea of what's your information, you have a son, you have a daughter, all that's in the exchange, and you can kind of figure out, okay, what are the similarities, what aren't, and then AI kind of takes over and then starts matching all together. Again, it's a Rubik's Cube type thing.
It took decades to analyze the human genome. If we had AI 20 years ago, we would be 100 years in the future right now.
When I was at UTEP and I was working in a lab trying to get into med school, and we would do this by hand. There was one PCR machine in the entire department, and you would like literally do this by hand. And now you can get it with the COVID test.
Right.
The COVID test was a PCR that was done immediately. Mm-hmm. So
we had four machines when I went there. So they're getting better.
Crazy, got a little better. But anybody that's more interested about obesity, I'm going to give my plug for my symposium.
Oh, yes, please do, yes.
Is we are having an obesity symposium at the Radisson Hotel on October 3rd. It's for mainly nurses and doctors. You can get credit, whether CME or CEU. And we have 7.5 hours of CME or CEU. And we cover all topics from pediatrics and obesity, cardiology, orthopedic surgery. We have a pulmonologist talking. I'll be talking about surgery. We have a dietitian, a psychologist talking. Okay. So I'd like to invite everybody to that.
And I asked your permission, but the telephone number that you can call to get to Dr. Clapp's office is 915-351-6020. I want to say thank you so much for joining us this evening. I love the twists and the turns that this conversation turned into.
We got into the weeds.
We get into the weeds. But sometimes it's like you just take that through. But this is called Slimming Down for a Stronger Heart. And if you want to watch this program again or any program that we have aired here with the El Paso Physician, there are 3 different places you can go do that. One is pbselpaso.org. Just look up the words, the El Paso Physician. It's actually on that website too. You can see the logo. The El Paso County Medical Society, that acronym is EPCMS, and that's a .com. And then YouTube, good old-fashioned YouTube. You see your kids playing on YouTube, you look at all it is, because it's been around a long time. YouTube.com, and look up the El Paso Physician on there. Thank you so much for joining us. I'm Kathrin Berg, and this has been the El Paso Physician.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician television program to your home for the last 27 years on PBS El Paso. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.